Hi, Chris Mustard. So I'm going to take you through medicine revision for this year's Viva. You have the Viva release. I'll be going through the questions 5 at a time, and I'll release this kind of video every second day until we're through all the questions. Now, to start off with, what am I going to do with each question? I'm most certainly not going to give you a detailed breakdown of each question. That will be counterproductive. I want you still to be able to study your own material and use these discussions purely as a sort of a broad compass as to what the rest of that questions road is that you are on the right track, which I think in actual fact you will be in most instances. But I think these questions may also provide the opportunity to convey some general thoughts around the Viva. And towards the end of July, we probably will have 1 or 2 sessions in person to catch up on and have mock Viva practice sessions. Right, so off to a start then. Before we go to question 1, in general, I would like to point out the following. You will have your STEM, and the opening answer to that STEM will always be, I would proceed to do a thorough history and physical examination if this is not already done. And because it is a System A issue, I will also be focusing in particular on System A. For example, a patient who has probable ascites based on the STEM, you'd be going, do a history and physical examination, but based on the fact that this is an abdominal presentation, I would in particular be focusing on an abdominal history and physical examination. I hope that makes that clear. Then you proceed to go on to further diagnostics. And there you would have your various categories you've sorted out for yourself. For example, it would be basic tests first, urine dipsticks plus minus an ECG, and then you would proceed to basic bloods and basic imaging and mention what those are. Thereafter, you go on to more specialized blood tests and imaging you would request. So it's important not to go right to an abdominal CT scan or go to a liver synthetic function test before you've asked for an EUC or asked for a basic X-ray or ultrasound of the abdomen. I hope you get the gist of that. Thereafter, you are going to think about treatment, and treatment would be then non-pharmacological, which could include even surgery, allied health referrals, and then apart from that, then moving on to pharmacological therapy. What is the main issue there? What are your treatment categories for that? And then apart from that, you would always at the end of your treatment plan think about potential referral to a specialist or call a specialist for advice. I would always think about that and have a low threshold to slot that in. For example, the one I mentioned to you, ascites. Once you've confirmed and worked up the ascites and the cause, and you think it is liver in origin, you would, for example, consider consulting a gastroenterologist. This tells me that you are aware that you can refer, that you will actually make that decision to refer and not try and do this all on your own. So you are also aware of where your limitations are. All of these are good things to exhibit and not imply. In the oral, don't imply anything. State explicitly what you are thinking. It makes it much better to get the information that way around rather than having to be prompted for it. Because you may be waiting for the question, but at the same time, if I'm asking you question after question just to get each answer out of you, it tells me that now I have to start leading you to get the answer. So you have to strike that balance between prompting information before I ask you, but also being ready to be asked questions that you are anticipating. But don't leave it all up to the examiner to tease it all out of you. So I hope that also makes sense. Right, so the first 5 questions are really not rocket science, so let's have a look at it. A 68-year-old woman presents with abdominal distension in essence. The findings are that of shifting dullness, and what are we looking for here? So abdominal distension, know your differential diagnosis, tell the examiner what you think about abdominal distension. But now, given that this patient has shifting dullness, you think that narrows it down to a more likely ascites. So what is this question about? It's about your approach to ascites. That is the core issue. Regardless of history and physical examinations and a graded diagnostic plan, the real core issue is you are going to tap the ascites and do a serum ascites albumin gradient. Why? You want to differentiate it into two categories. What will tell you which diagnosis this patient has, low or high gradient. And out of all of that, you'll be able to say, right, looks like a low gradient, high gradient, and the list of each of those categories. And in main, you're really trying to differentiate between portal hypertension versus things that look like almost like an exudate in pleural effusion. That could be, for example, malignancy. So you're thinking liver disease versus other diseases, and malignancy and infections are on top of that group of things. So hopefully that makes that clear. But still, you are going to use the structure I just mentioned before we started doing the questions. Right, so a medicine classic, ascites, your approach to ascites, and how that differs from a pleural effusion approach. Question 2 is a patient who is 70, has type 2 diabetes and an episode of a facial asymmetry and weakness which lasts for 5 minutes. Right, so what is the issue here? The issue here is TIA and stroke. You test your knowledge around managing this, but also identifying risk factors for this, how you do your neurological examination, that you'd also be asking, was there any arm weakness, was there any leg weakness, and your physical examination, checking all those things, but also checking for things like atherosclerosis. You'd be listening for breeze. You'd be checking whether there's any ischemic heart disease, signs of heart failure, or any other vascular issues, for example, peripheral arterial disease signs. Just briefly, not in detail, don't get sidetracked. The main issue is still stroke and TI. Remember, these questions flow very quickly, and if you know your stuff on the basics, like a question like this, that should be more than enough for you to speak about during the exam. Right, so further concepts here would be how you would do risk factor identification and modification in your treatment plan. It would be knowing how to manage a stroke, and you should all have seen this on the wards. So you'd be putting the patient on telemetry, you'd be doing diagnostic imaging tests with both regards to the stroke, but also trying to find the source of the stroke, and you'd also be wanting to apply earlier referrals to which specialist here, right? So that's the question, which specialist, right? So that will be a stroke physician if this is available, otherwise a neurologist, otherwise a general medicine physician who is on call in your regional hospital, right? So those are the parameters in Maine that this is all checking. There's an abundance of information on the management of TI stroke, so have a very clear pathway that you have in mind for history, physical examination, identifying risk factors in that. Furthermore, then on special tests, what they are in Maine, why you are doing them, and then what is your treatment, how do you do risk reduction, why do you give a statin, why do you give antiplatelet therapy, is it one or two agents, what's the duration for that, and then you move on to your other parameters, including my referral system. Right, in question 3, an 82-year-old woman presenting with shortness of breath and is found to have a moderate-sized left-sided pleural effusion. Right, so how would you assess and manage her? Right, so same structure as the other questions. Now we can start shortening our replies to that. The main issue here is your approach to a pleural effusion. The classical concept of a transudate and exudate, no lights criteria. There are 3 of them. If you have 2 out of 3, it becomes more specific, even more so when it's 3, but it can still misclassify. Know that there are some other tests that can help you differentiate an exudate from a transudate. Don't get bogged down in too much detail here. And then you must know your list of causes of a transudate and an exudate, and basically the main managements of each one of those, right? Question 4. Patient that presents with daytime sleepiness and heavy snoring. Right, what is the main issue here? What do you think is wrong with this patient? Patient seems to have obstructive sleep apnea, but could also have other upper airway issues. So you would want to assess this patient. Does he have obesity? Yes, no. Does he have any airway issues? How do you confirm the diagnosis? Important is a sleep study. That is the other crucial point here. How do you interpret that sleep study? Just the main concept. What does sleep apnea actually look like? After saying, I want a sleep study, give me at least the main headlines of how you'd interpret that sleep study. And if a sleep study is not readily available or the wait is too long, one can do a similar study at home, a home-based sleep study. That's an initial screen. How do you treat sleep apnea? There's something you can do as a general practitioner, but there's also something that a sleep physician does. What machine do they use? Those are the things I want you to go and have a look at. And in all that you'll be hearing, there must be a sleep physician in that referral system. Yes, there is. Go and have a look at that. Create your structure here. But the main issue here is sleep apnea. Right, so you've got a 26-year-old female patient in question 5 with tiredness, palpitations, and heat intolerance. She is young, so that fits in with probable thyroid disorder. Then, surprise, surprise, she has a diffusely enlarged thyroid. Right, so this fits in with that whole schema of ours. Here you'd be elucidating what the findings are of hyperthyroidism, what the causes are, how you would start treatment, what are the main pharmacological agents, and surprise, surprise, you may consider referring this person to an endocrinologist. Great. I think that those first 5 questions are a wrap. I hope you find that this was useful. The following sessions will probably be a lot shorter now that we've gone through the main structure. And just once again, I just want to point out that none of my answers were detailed in any formal way. There will be gaps in them. That is intentional. You are supposed to fill those gaps. What I just want you to get is what is the main issue of each question. And as we go along, we may discuss some Viva strategies which may be useful. Right. See you next time. Bye-bye.